Again, my name is Al Taylor. I'm a medical informatics officer in the Office of Technology at ONC. And I'm joined today by Papia Paul, who's a public health analyst, also in our Office of Technology. Next slide, Matt. This is a reminder that today's presentation is based on the provisions contained in 45 CFR Parts 170 and 171. While every effort has been made to ensure the accuracy of this restatement of those provisions, the presentation is not a legal document. The official program requirements are contained in the relevant laws and regulations, and please also note that other federal, state, and local laws may apply. Next slide. Today, we're going to talk about the United States Core Data for Interoperability, or USCDI, in general, including what's included in the version 1, which we published last March, and recently published draft USCDI version 2. We'll also talk about the Standards Version Advancement Process, or SVAP, along with the recently published approved standards for 2020 that are part of the SVAP. And at the end, we'll answer some frequently asked questions about USCDI and SVAP, as well as provide links to some resources that will be helpful for you. Next slide. So let's jump in and first talk about USCDI. So what is USCDI? First of all, USCDI is an ONC-defined set of health data that must be expressed in certified health IT and must be made available for exchange according to certain exchange standards such as FHIR or CCDA. It's comprised of data elements that represent individual concepts such as medication, allergy, procedure, or health concern. These data elements are grouped into data classes of related elements. But the data elements in any one class can also be used for other purposes related to other data classes. For example, the care team member data element can be used to identify those participating in a patient's care, but it can also be used to describe the person who performs a procedure on the patient. Some USCDI data elements must be represented using specific health IT vocabulary standards, such as SNOMED, LOINC, or RxNorm. The data elements with these applicable standards are those where there's greater consensus on which of these standards should be used in particular cases. For example, LOINC is recognized as being the best standard for most lab tests, SNOMED to represent allergies, and RxNorm to represent medications. The applicable standards for USCDI version 1 data elements can be found on the USCDI website, healthit.gov/USCDI, as well as in the standards document, the USCDI version 1 standards document, which is also found on the USCDI website. We put the links in the chat window, but if you joined after, you may not be able to see them, but we'll repost those links in just a couple minutes. USCDI focuses on core data, which is why it's part of the name. Those core data requirements apply to patient care, the data elements required for patient care, for patient access to the records, or what information a patient needs to be able to see, and certain other exchange and interoperability uses. It's not intended to include all of the data elements that may be needed for all data collection, data exchange, or data reporting purposes for all programs. It was not meant to be that way. Also, USCDI is what we call content exchange standard agnostic, which means that the USCDI defines the data elements, but it doesn't define how these data elements are used using these exchange standards, such as a FHIR resource or a CCDA document. Next slide. So this is the first version of USCDI that we published last March. USCDI is a modest expansion of the Common Clinical Data Set, which was also used to define required patient data elements for several different use cases, including patient access and exchange. The Common Clinical Data Set was defined in the ONC 2015 edition certification. USCDI version 1 added 3 new data classes: allergies with the data element substance medication, the substance drug class, and the reaction, all part of the allergies and intolerance data class. The clinical notes data class added 8 new clinical note types, and they're listed here. We also added a provenance data class, which adds provenance data to all the other data classes as well. The new data elements within provenance are author organization and author timestamp. USCDI also added several patient demographic data elements, including current and previous address, phone number, and email address. It also made capture and exchange of several pediatric growth-related vital signs a requirement, whereas previously they were optional using prior certification editions. Next slide. The USCDI as a data set is a required component of these listed certification criteria, which are all new or updated in the 2015 edition Cures update, which we published last year. What this means, for example, for the new standardized API for patient and population services, or G10, is that systems who implement API technology, application programming interface technology, must respond to individual patient requests for their data that are mapped to all of the USCDI version 1 data elements. So the API has to be able to respond to each of the USCDI data elements. For the next criteria, B1, or transitions of care, health IT modules that are certified to this criteria must be able to create and send a transitions of care document capable of containing all of the data elements included in USCDI version 1. Just as a reminder, this does not mean that all of the information has to always be in these documents or in this exchange of information. It just means that systems must be able to capture and exchange these data elements. Next slide, please. This timeline outlines several key dates related to USCDI and SVAP, as well as to information blocking and electronic health information. The first date is the effective date for the Cures update criteria, or June 30th of 2020. What this means is that developers at that time could begin certifying or updating their health IT modules to the 2015 Cures update, 2015 edition Cures update criteria, and a small number of health IT developers have already done so. On or after April 5th of 2021, so just a couple weeks from now, an actor must respond to a request to access, exchange, or use electronic health information with, at a minimum, all requested data elements that are part of USCDI. The next date is October 6th of 2022. At that point, the definition of what must be included in an information request is expanded from the USCDI definition to the greater definition of EHI, or electronic health information, as defined in section 170.102. The other key date I wanted to mention is December 31st of 2021, which is when all provisions of the 2015 edition Cures update must be met. Next slide. In our final rule, we not only established USCDI version 1, but also a public stakeholder-driven process to expand the data elements and data classes in USCDI through collecting submissions in the ONC new data element and class submission system, or what we call ONDEC. ONDEC opened in July of 2020, and submissions that were made before the end of October of last year were evaluated and considered for inclusion in USCDI version 2. Those published submissions are publicly available for review and comment, and those comments can contribute to these data elements being considered for inclusion, both in USCDI version 2 as well as future versions. ONDEC is open and available year-round and submissions that were received since last October will be evaluated and considered for the next version of USCDI. Next slide. Okay. Submitters through the ONDEC were given a series of questions related to the maturity of each data element, and ONC reviewed these submissions based on these four main criteria. The first is the extent to which the data element is represented using health IT vocabulary standards or other technical implementation standards. The next is the extent to which the data element is currently being used within health IT systems. So not just coded, but actually in use, being captured in health IT systems. And the degree to which it's being used, meaning is it being used only in pilot programs or is it being used in full-scale production systems? The next criteria is the extent to which the data element is exchanged between different systems using vocabulary exchange standards that were part of the first criteria. And the final criteria is the number or percentage of patients, providers, or events that use or exchange this data element. We sometimes refer to this as broad applicability or breadth of applicability. This is important because adding this new data element to a future version of USCDI means that health IT developers will have to update their systems to the new version and make these updates available to all of their users, not just the ones to which it most specifically applies. Based on these criteria, the submissions were assigned as a level of comment, level 1 or level 2, based on this maturity, feasibility, and applicability. Level 2 being the highest and comment being the lowest. Next slide. So who submitted data elements through ONDEC? It was a lot of folks from a lot of different areas of healthcare. We had 64 individual submitters representing almost 50 different organizations, including federal and state agencies, as well as individual submitters. This doesn't include all of the folks, over 150 people so far, that have contributed comments and other input to the submissions that were already made. The breadth and depth of this input is also important as it demonstrates how many different use cases and interoperability needs were represented by these submissions, and how many different use cases and interoperability needs ONC needs to consider addressing as we make these updates in the future. Next slide. In total, ONC received over 660 individual submissions for data elements during the 5 months that the ONDEC was open. ONC evaluated each of these submissions based on the criteria that we discussed earlier. We determined that almost half of them were either duplicates or subsets of other submissions. One example of a duplicate submission was APGAR score. We received 7 separate submissions for APGAR score, but only one of them was published as only one of those submissions was published, excuse me. An example of a subset for different types was for different types of weight measurements, including a mother's pre-pregnancy weight and a baby's delivery weight. Since all of these were for a different type of weight measurement, and the USCDI version 1 already includes the vital sign data element for a patient's weight, these were not published, but rather were considered merged or duplicates of the USCDI version 1 data element weight. ONC used those criteria that we mentioned before and determined that 109 of those data elements were mature enough to be designated as level 2. It's from the level 2 list that we selected data elements to be added to draft P2. And it's clear to ONC and most others that despite the maturity of all of these submissions, we couldn't add all 109 data elements to draft version 2 because of the amount of the standards development required, the development of the health IT capabilities, and the implementation burden and workflow impact on providers and other implementers would just simply be excessive, particularly in the face of responding to all of the different requirements for provision of care during the coronavirus pandemic. Next slide. And so we developed a prioritization, some prioritization criteria to apply to these level 2 data elements to come up with a reasonable set to add to version 2. The submissions, first of all, the submissions had to represent significant gaps in USCDI version 1 concepts. We gave priority to data elements that were already required by other ONC certification criteria, which means that it would mean minimal additional development or workflow impact on systems that were already capable of capturing it. We also gave consideration to the amount of technical standards development that would be required to be able to exchange this new data element using, for example, using the FHIR or the CCDA standards. An example of this developmental burden was encounter diagnosis, which is already a required data element for producing a transitions of care document. Given that the new USCDI data elements would also need to be integrated into those exchange standards I mentioned, we gave consideration to the impact of updating these exchange standards and the feasibility of being able to modify those technical standards to accommodate this new data element, which they would be required to be able to handle. And finally, we considered the aggregate burden of development of the health IT modules, so that the EHR developers and vendors, and the aggregate impact on the implementing providers and how it impacts their workflow. Next slide. On January 12th of this year, we published the draft USCDI version 2. Out of the 109 data elements, 109 level 2 data elements, version 2 added a total of 9 new data elements and 2 new data classes. The new diagnostic imaging class included 2 new data elements, diagnostic imaging order and diagnostic imaging report. The new encounter information data class added 3 new data elements, encounter type, encounter diagnosis, and encounter time. 2 new data elements, provider name and provider identifier, were added to the care team members data class. And the problems data class added date of diagnosis and date of resolution as data elements. And finally, 3 data elements that were part of the clinical notes data class were reclassified. And those are indicated by the blue arrows. The 3 data elements that were part of the clinical notes data class were reclassified into different data classes, although the guidance on how to implement diagnostic imaging narrative, lab report narrative, and path report narrative did not change. I also want to mention that the data elements that were not selected for draft USCDI version 2 remain in the system, in the ONDEC system, for at least the next 2 years. This allows for additional development work on the data elements, to move them up to level 2, or to do additional work to improve the feasibility of implementing them, and for these items to be considered for additional future versions of USCDI. So as we consider what to add to the draft version 3 of USCDI, we'll take into account the data elements from level 2 that had yet to be added to USCDI. Next slide. At the beginning, I mentioned that some of the data elements were represented by certain health IT vocabulary standards. These vocabulary standards are the ones referenced by various data elements in USCDI version 1. As you might expect, these standards all have regular version update cycles, most of them at least once a year. As part of the draft USCDI version 2, we propose to update all of these vocabulary standards to their most recent versions as of the time of publication of USCDI, the final USCDI version 2, which we expect to happen in July. So these are the current as of a publication date. These ones on the left and the right, are the ones that are the vocabulary standards that are current as of the publication date, but we expect that some of these may need to be updated further to the most recent version as of July of this year. Next slide. Now that we've published draft version 2, we're seeking public comment including input and recommendations from our Health IT Advisory Committee on what was included in USCDI version 2 and what was not included, including the ones that were in level 2 or the lower levels. Public comment will be accepted through the USCDI website until April 15th of 2021, so just a couple weeks from now. ONC will aggregate all of this feedback and consider and take all of that into consideration while we finalize the USCDI version 2 in July of this year. Once USCDI version 2 becomes final, it will be considered for addition to the list of approved standards that are part of the Standards Version Advancement process, or SVAP. The SVAP will allow Health IT developers to update their systems to a newer version of adopted standards included in the ONC certification program, and then provide these updates to their customers. I'm going to now pass it over to my colleague, Papia Paul, who's going to go into more detail about the SVAP.
Thank you, Al. Hi, everyone. So I'm Papia Paul, a public health analyst, also with ONC's Office of Technology. Today, I'm going to do an overview of the Standards Version Advancement process, also referred to as SVAP, and how Health IT developers participating in ONC's Health IT certification program can take advantage of the SVAP flexibility for their certified Health IT. I'll also touch more on how the SVAP can be leveraged to update to newer versions of the USCDI in the future. Next slide. First off, a little bit of background and a quick refresher. The 21st Century Cures Act required, and ONC established, the conditions and maintenance of certification requirements for the ONC Health IT certification program. And these express the initial and ongoing requirements for Health IT developers and their ONC certified Health IT modules. The Standards Version Advancement process is a component of ONC's Cures Act Final Rule, which established the SVAP flexibility to allow Health IT developers to voluntarily incorporate newer versions of adopted standards as part of the real-world testing, condition, and maintenance of certification requirement. So using SVAP, developers participating in our certification program are now allowed to voluntarily update their Health IT modules to use approved newer versions of standards than those adopted in regulation for use in our program, so long as certain conditions are met. The introduction of this flexibility in the certification program is beneficial in a number of ways. It allows for more advanced versions of standards to be approved for use under the program in a more timely and flexible manner. So in many cases, not having to wait then for new versions of standards, such as the USCDI, to be adopted through continuous rulemaking or lengthy rulemaking that might only occur every few years. So rather, the process for identifying, approving, and making available newer versions of standards takes place on an annual cycle to keep pace with the industry standards development efforts. And particularly as new and more advanced standard versions become available, it'll give developers the ability to conduct ongoing maintenance on their certified Health IT modules to incorporate these new versions, which we feel is essential to supporting interoperability in the real world. Next slide. So as mentioned, the Standards Version Advancement process takes place on an annual cycle for which ONC has established a process to receive public input on eligible standards that can be adopted through the SVAP. So working with industry stakeholders and providing ample notice, ONC has developed a collaborative public comment process to solicit feedback to help identify newer versions of standards that are also ready for use in the certification program. The very first public comment period actually just took place this past fall from September to November to help determine our approved standards for 2020, which I'll get into more in a moment. But for awareness, a list of the eligible standards, along with their versions for consideration, are available on the process page for the SVAP at the URL noted here. And that page also includes more on the annual approval process. Next slide. I'd also like to take a moment to make a quick note regarding eligible standards. It's important to know the SVAP flexibility is currently limited to those standards adopted in the certification criteria required to meet the real-world testing condition of certification. So this includes the B criteria for care coordination, C1 through C3 for the clinical quality measures, E1 for patient engagement, the H criteria for electronic exchange, the F criteria for public health, and G7 through G10 for APIs. Next slide. So ONC completed the review and assessment of comments for the first SVAP cycle, and the approved SVAP versions for 2020 were announced back on January 12th. The table here outlines the approved newer versions of adopted standards alongside the impacted certification criteria under the program, which for this cycle are C3, Clinical Quality Measures, CQMs, report, E1, View, Download, and Transmit to Third Party, and F7, Transmission to Public Health Agencies, Healthcare Surveys. After a 60-day delayed effective period, the new versions became available for use in the certification program as of March 12th, which was just last week. So developers can start updating their modules to these approved standard versions within the program if they so choose. Going back to the predictable and timely approach for making newer versions of standards available, just as the annual SVAP approval cycle, once that is complete, we anticipate announcing the approved standards each January, followed by a similar delay of at least 60 days before they become effective each March and are available for certification. For more information, though, I'll refer you to this URL noted here for our SVAP certification page, which also includes this current list of approved SVAP versions, and it'll also direct you to operational information for the certification program. Next slide. So getting into SVAP and certification and how does all this work exactly? Again, as mentioned, the SVAP flexibility is limited to the standards adopted in the criteria to meet the real-world testing condition of certification requirement. So for the approved SVAP versions, developers choosing to leverage the SVAP flexibility can do so on initial certification of their health IT module or to maintain certification for their module. Broadly speaking, developers will need to ensure the updates to the newer approved standard versions are effectively implemented and also adhere to all applicable program requirements, such as ensuring their real-world testing plans and results for their certified health IT address the updated standards. Taking a deeper dive on the right into the conditions that need to be met to take advantage of the SVAP flexibility, health IT developers updating their already certified health IT modules are also required to provide advance notice of their plans and anticipated impact to both their affected customers, as well as to their ONC authorized certification body, or ONC ACB, with the end goal of giving customers ample advance notice to ask questions and plan for updates. For all developers voluntarily choosing to avail themselves of SVAP, they'll also need to successfully demonstrate conformance with the newer approved versions of adopted standards to confirm that they're meeting the updated requirements. And lastly, again, developers must ensure they're maintaining their updated health IT modules to meet all applicable program requirements. Next slide. So getting into how this all fits together, as Al touched on earlier, because the USCDI is adopted as a standard, the SVAP allows health IT developers to voluntarily have their products certified to newer approved versions of the USCDI in the future without waiting for rulemaking to update the USCDI version listed in regulation. Next slide. So revisiting the timeline for the USCDI alongside the SVAP now. So at the top, we note the public comment periods for newer versions of the USCDI before those drafts are finalized and become available. Along the bottom, we note the recurring process to identify and approve SVAP versions of standards, as well as announcing and making those approved versions available in the certification program. Specific to USCDI version 2, note it will only be available for comment this year. And again, that public comment period is currently taking place until April 15th. So since we've already closed out our cycle for the approved standards for 2020, the USCDI version 2 will not be eligible for SVAP until it is finalized and published in mid-2021. At that point, the finalized USCDI version 2 would be eligible for consideration in the next SVAP cycle taking place this year, and if included in the approved standards for 2021, would be announced in early 2022 and available for certification at that time. And with that, as promised, we do have a couple of frequently asked questions on the USCDI and SVAP that we'd like to cover. So I'll actually turn it back over to Al to kick us off.
Thanks, Papia. Matt, can you advance the slide, please? The first question is related to clinical notes in USCDI version 1. And we've gotten this question a lot. We actually got the question, we got the question in the chat as well. So many organizations have clinical notes within their systems that are different than the 8 clinical notes that were included in the USCDI version 1. And because the ability to exchange there's concern that a system may be subject to information blocking if they don't provide sufficient information in response to a request for clinical note data. Many of the note types that are stored within different systems are different than those 8 systems, and so those 8 clinical notes. And so the question is there a requirement or is there a specification as to do all clinical notes that are stored within systems have to be mapped to those existing USCDI version 1 clinical notes? And the answer to that question is no. While we provide general definitions and scope for the 8 clinical note types, ONC doesn't specify what each clinical note type contains, nor does it specify which other note types have to be mapped to those 8 clinical note types that are part of USCDI version 1, and therefore have to be exchanged in response to a request for a particular clinical note type. So for example, providers or developers may choose to map nursing notes or other note types to the progress note because of the way progress notes have been defined and how ONC defines it within that standard, as including content recorded by physicians, nurses, consultants, and therapists. That's our definition. It doesn't say that every note ever recorded has to be designated as that particular note type. So mapping of these note types to progress note, the progress note data element or other data elements in clinical notes, and then exchanging them in a response for a progress note would achieve the goal of improving patient access and data exchange. Another example is operative note, which is not a USCDI version 1 data element, and whether or not an operative note can be mapped to the procedure note data type within clinical notes and exchanged in response to requests for procedure notes. This also would be acceptable, but it's not a requirement. Another important reminder is that regardless of an organization's decision about what to map and how to map clinical notes to the USCDI clinical note data elements, one of the dates that I mentioned earlier was October 6th of 2022. At that time, an actor must respond to a request for electronic health information based on the new definition of electronic health information, which was previously defined as limited to the content in USCDI. Following that date, the definition of EHI expands to go beyond what was only required in prior to that date. So what that means is that whether you've mapped certain notes to one of those 8 USCDI clinical notes, you may be required to exchange those other clinical note types after that date, based on their inclusion in the definition, the broader definition of electronic health information. Next slide. So the next question is, will I be required to update my certified health IT module to USCDI version 2 when final? And the answer to that question is no, it's not going to be required, at least right now. So first of all, USCDI is not final, but once it is final in July of 2021, it will be considered as a candidate for the standards version advancement process that Papia covered. And that list that we published in January of this year, the approved standards for 2020, we'll publish a new version of that around January of next year. If USCDI is part of the 2021 approved standards, then health IT developers who've already certified their health IT modules under the certification program will be permitted, meaning voluntary, to update to newer versions of USCDI, including version 2, again, within the scope of the certification criteria, without having to retest or recertify their systems to the new version. Health IT developers seeking to obtain initial certification, so those who have not yet certified to the Cures update prior to the availability of USCDI version 2, they will have the option of certifying to USCDI version 1 or USCDI version 2 based on the provisions of the standards version advancement process. Next slide. If I voluntarily update my certified health IT module to USCDI version 2, do I need to include all of the new data classes and all of the new data elements that are part of USCDI version 2? And the answer to that question is yes. Under the ONC certification program, a health IT developer must update all of their new data, all of the new data classes and data elements to meet the USCDI version 2 requirements if they elect to update their systems to USCDI version 2. For example, a system would not be able to update to only the data class encounter information and not also update their systems to the data class diagnostic imaging. And that question or example comes up because in some cases, some systems are not accustomed to or used to managing diagnostic imaging reports, for example. But under the provisions of the certification program, to update to any of the USCDI data elements, USCDI version 2 data elements, one would have to update to all of the new data elements and data classes. And I'm going to turn it back over to Papia, who's going to address a couple of FAQs for the SVAP program.
Great, thanks, Al. So the question here is, when can I update my Certified Health IT module to USCDI version 2 in the ONC Health IT certification program? So as we covered, SVAP approved standards will be announced each January. This will be followed by a 60-day delayed effective period, after which newer approved versions of adopted standards will be available for certification. Specific to USCDI version 2, if that version is included as an SVAP approved standard for 2021, then health IT developers may voluntarily begin updating their certified health IT modules in the program no earlier than 60 days after the announcement in January 2022. Next slide. Next, we have, do I have to update my certified health IT module to all of the approved SVAP versions? And the short answer is no, you do not. A health IT developer is able to choose which of the newer standard versions approved for use through SVAP to include in its updated certified health IT module, and is able to do so on an itemized standard by standard basis at its discretion. So if you choose to leverage the SVAP flexibility, you may voluntarily update your module to any or all newer standard versions approved for use, depending on the certification criteria that reference the standard. So if several different approved SVAP versions that impact different certification criteria within the scope of a module are available, you're able to just update one certification criterion to one or more of the applicable new standards. You would not have to update your certified health IT module to all of the approved SVAP versions all at once in order to take advantage of the SVAP flexibility. To expand on this a bit, with the approved standards for 2020, none of the newer standard versions impacted more than one certification criterion. So if you have a module certified to, or that you'd like to certify to, any of the 3 criteria, which again were C3, E1, and F7, you could leverage SVAP to update or not update each of those as you see fit. In a future SVAP cycle, an approved standard version could impact multiple criteria, in which case, again, you could choose to leverage the SVAP to update one criterion that has the approved version and not another, or also update one criterion at a time to the approved version. One criterion could also in the future have multiple standards approved through SVAP, in which case you could update or not update each of the standards within the criterion as you'd like. So again, there's quite a bit of flexibility in how developers choose to leverage the SVAP within the certification program. So those are all the FAQs we have for you today, but we're always tracking stakeholder feedback that we hear or receive, such as those that we're receiving during this webinar, so that we can continue to take that back and to provide guidance and clarification as needed. There are just a couple of resources that we'd like to highlight. Next slide, please. So you've heard us reference throughout the presentation a number of USCDI and SVAP resources useful for learning more about these initiatives. So for the USCDI, we have the link here to access and comment on the USCDI, including the draft USCDI version 2, which again is available for public comment until April 15th. So you can follow this URL here to submit your comments. We also have the link here to submit to the ONC New Data Element and Class, or ONDEC, submission system. For the SVAP, we have the links where you can view information on the annual SVAP process, including the list of eligible standards and their versions for consideration. You can also obtain the current list of approved SVAP versions, including the approved standards for 2020, which again, as a reminder, are now available in the certification program, along with operational information for certification and learning how to either certify or update to those impacted criteria for the approved standards. Also related to certification, we've included a link where you can access reference documents and other resources for our ONC Health IT certification program. That link will also direct you to additional resources for our certification programs and direct you to the space on the ONC website where you can learn more about how the program is structured, the certification process, and how to participate. Next slide. And lastly, for awareness, throwing in a plug here for a new communication tool that we have here at ONC, the ONC Standards Bulletin. This is where you can sign up for and also view previous alerts for healthcare stakeholders that include important updates about ONC health IT standards, initiatives, and other efforts such as the USCDI and SVAP. Next slide. So I'll turn it over to you if there was anything you'd like to cover before we close out.
Yeah, Poppy, I did want to, before we close out, I wanted to give just really a quick overview of the USCDI website because I referenced several different parts of it. So the URL is health IT. The short URL is healthit.gov/USCDI. And it's available through the ONC website. There's a couple of different pieces that I want to show you. First of all, with respect to draft version 2, the second tab shows all of the data elements that are included in the draft version 2, including the ones that came over from version 1, as well as the ones that were added to the draft V2 from the level 2 data elements. So you can review them all here. And also, most importantly, is you can comment, you can contribute to the information available around any particular comment just by clicking on individual data element names, individual data class names, and add your comment there. You have to be logged into the system, which is a fairly simple process to do, but you have to log into the system to make your comment. We'll take all of these comments into consideration, but it allows for the public to get engaged into the development process for each of these data elements. You can also drill down to the individual data elements and make comments or at least review and just to get a better sense as to all of the things that are in USCDI. Back to the main page, you can also review the level 2 data elements, including the ones that were and were not included in draft V2. This is where we probably are going to get the most, excuse me, the most public comments. Is comments on individual level 2 data elements. You can also look at the level 1 and the comment level data elements that were submitted. In addition to accepting public comments, you can also submit data elements, new data elements that would be considered for the version 3 starting at any time. We've already gotten a few submissions. This is also a good place to also look at the standards document itself, including this is the original, the USCDI version 1 that we published last year, and within that you can see where the applicable standards are for individual data elements. You can also review the version 2, the draft version 2 as a separate document. You can make comments on draft version 2 through adding comments to any of these tabs, because the comments are consolidated across all of these tabs. But you can make comments here related to draft V2 as well. And again, if we didn't already say it enough, comments are being accepted until April 15th of this year, at which point we're going to have to close the door on additional comments that might impact our decisions around making for finalizing the USCDI version 2. That's what I wanted to cover from about the USCDI and the ONDEC website, and I'm going to turn it back over to Papia for a minute.
Great, thank you, Al. So that concludes our webinar today on understanding the draft USCDI version 2 and the standards version advancement process. Thank you for joining us. We hope you found it informative. As we mentioned at the start, we will be making the webinar slides as well as the recording available on our website soon, so stay tuned. And as always, whether it's specific to the topics covered today or more general, please feel free to engage with ONC via one of the many ways listed here. Although we have highly recommended the Health IT Feedback and Inquiry Portal for sharing any Health IT related feedback or concerns that you'd like to bring to ONC's attention. So thank you all again. We will end this webinar now. Hope you have a great day.
Thanks, everybody.